a version of this project or this paper this spring in the Penn Law Review Symposium on Health Reform that is in an early draft now. So I would particularly appreciate either today or by email later any feedback you all might have. And one thing I mentioned that I'm looking for in particular is literature in the health policy world, or more broadly, thinking about theoretical incoherence and that kind of scholarly conversation in the world outside of the legal literature. So if you have any suggestions, please send them to me. So I'll spend about 25 minutes or so describing this project, and then I'll open up for comments and questions. I'm sure many of you are well-grounded and think about health insurance to a large degree, so I won't spend a long time talking about it. But as background, let me just spend a minute talking about one aspect of the regulation of health insurance that's particularly relevant to this project. So as I mentioned briefly, insurance is a tool to spread risks. These risks can be spread narrowly, they can be spread among a rather homogeneous group of people, or they can be spread more broadly and among a more heterogeneous risk pool. In my past work, I've discussed a process of regulatory fragmentation of health insurance markets into diffuse, more homogeneous risk pools, so that people tend to spread risks more narrowly, not among that many people, and among people who are pretty similar to themselves. So this law begins to mend this regulatory fragmentation. Through the ACA, I suggest that health insurance is shaped into what I would call a more solidaristic structure. And when I talk about more solidaristic health insurance, I'm referring to using insurance as a mechanism where risk becomes more collectivized, or we spread risks more evenly and equally among a broader group of people. So through the ACA, this has been done through several different approaches that both regulate insurance markets and start to restructure health insurance markets. So for example, we have guaranteed issue of health insurance, where insurers must issue health insurance to any applicant. They can't reject people any longer. We have new rules for risk rating. So it used to be that insurers could issue insurance, could decline insurance, and could price insurance based upon a whole number of factors that varied somewhat state by state. Under this law, there are a very limited number of factors which bring the range of different prices of health insurance into a much smaller range. And then we have restructuring through the creation of exchanges and mechanisms and requirements that insurers create broader risk pools among all of their insureds in a state. And on top of that, we have an individual mandate. So we're now requiring people to carry insurance. So we create a structure where risk is pooled more broadly, and then we require most Americans to participate in that structure. So then we increase the number of people in these risk pools. So as insurance becomes a more solidaristic structure, redistributing costs among a broader population more equitably, what are we expecting it to do? More precisely, what is the risk that we're expecting this more solidaristic health insurance structure to mitigate in a collective way? That's the question of this paper. That's the focus of this paper. So I'll explain today what I see are three different things we're expecting health insurance to do, three theories of what health insurance can do. And each one puts different types of potential harms as the priority under the umbrella of insurance. So on the right here, we can see harms to wealth. On the left, harms to health. And across the top, what I'm going to call the brute luck harms. And I'll explain what each of these means in more detail in a moment. But let me just note two things when we're looking at this image, which we'll see throughout the presentation. So first of all, these theories are neither mutually exclusive nor are they fully overlapping. There are areas where they overlap, where once you're mitigating a harm to health, you'll also mitigate a harm to wealth. But there are areas where they don't overlap at all. And the harms can be organized on a spectrum from preventable to random. So harms at the bottom might be things that we could prevent on our own, and at the top might be more random harms, like something that's genetic or that you're born with, or something that's the cause of an accident that was not preventable. So I'll talk more about the relevance of these categorizations as I go. I call the first theory, this on the left, the harms to health, the theory of the health maximizing notion of health insurance. So each theory has a particular goal and has key questions that have to be answered in order to implement insurance in a way that can achieve this goal. For this theory, the goal is that health insurance should serve to protect broadly against the risk of poor health, thus mitigating harms to health. Insurance then serves as a mechanism to redistribute the costs of mitigating disease, illness, and injury among the population at large so that we can collectively use insurance to promote a healthy population. Now, in order to do so, there are some tough questions that need to be answered. The first is determining which categories of care are high value. So how do you, when you think about categorizing care, how do you prioritize categories that will maximize health? So you can imagine, if you think about the Oregon plan, one of the things they had to do in the early stages of implementing this plan is to develop a list of what are the highest value of categories of care that insurance will definitely pay for, and what are diminishing value as you go down. And at some point in their plan, they had to draw a line and say, anything below this line this year, our insurance plan is not going to cover. So then once you develop these categories of care, thinking about what are the higher value in terms of maximizing health, you also have to think about what medical treatments are worth covering in each category. And you can base this, for example, on comparative effectiveness research or some other way of determining the relative value of interventions for a particular injury or illness. So if we decide that treating a particular kind of cancer is high value, then we have to think about what are the right treatments that insurance should pay for to treat that kind of cancer. The final question here is maybe one of the stickiest questions in health insurance and health reform, which is the question of whose health is valued most. So as we know, this is a limited resource allocation question when we think about the value of a life and whether we count some people's lives more than others as we spend insurance dollars. So is the life of a newborn or an adolescent or somebody who is part of the working age population more valuable than the life of an elderly person? This is the question that was behind the claims of death panels in health reform, but is one that has to be addressed to think about how do you use insurance dollars to maximize health among the population. So where does this play out in the ACA? It plays out in a number of places, and I'm going to give a few examples of where each of these theories play out, but these are not meant to be comprehensive. These are simply illustrative of where some of the most popular policies of the ACA, or most talked about policies, play out. So here we see things like the coverage of preventive care without cost sharing, which is required as of this past fall for all non-grandfathered health plans. So this says that for preventive care, for certain categories of preventive care, people can get that care without any cost sharing. They don't have to pay any of their own dollars. Insurance will fully cover it. Another example is the creation of essential health benefits that certain health plans must cover. And in the past, the mandated health benefits that plans had to cover were developed at a state-by-state level. The new law creates a federal floor. All plans have to cover X, Y, and Z. And finally, at the same time, while we're seeing health plans have to cover a broader range of services, we're seeing investments in prevention and primary health infrastructure so we can build capacity to actually deliver on these services as the reform is rolled out. So we see investments in education and funding residencies and in reimbursements in order to get the delivery system stronger in the areas that will help to promote health. The second theory is that health insurance should mitigate against harms to wealth. I call this the true security notion of insurance. It's a name I take from a 1999 book by two law professors, Gratz and Mishaw. And the notion here is that the primary goal of insurance is to protect against risks to wealth, especially in addressing medical poverty. So insurance here instead becomes a mechanism to pool and redistribute costs of care that would cause an insured unreasonable financial burden. When we think about implementing this policy, then we have to ask, what is an unreasonable financial burden? So how do we define financial insecurity? How do we determine when health insurance should kick in? We could develop it based upon a percentage of income. So it might be that some percentage, more than a certain percentage of income is too much to expect a person to pay on medical care costs. For example, if we said that 10% is the right number, it might be that somebody who earns $40,000 a year has to spend the first $4,000 out of pocket for their medical care costs, after which insurance would kick in whole or in part. But then it raises other questions. So what if 10% is the number? Does somebody who's earning $500,000 a year also have to contribute 10%? Does that person contribute $50,000 once insurance kicks in? And is that the right level for determining financial insecurity there? Or is it that somebody earning $500,000 a year could really afford $100,000 before financial insecurity kicks in? So do we determine it based on a simple percentage of income? Is it based on diminished standard of living? How do we define financial insecurity? In the ACA, these true security policies are some of the most popular, and these are actually some of the policies that received bipartisan support in the early discussions of the bill, and some that I suspect were least likely to see repealed if anything gets attacked in the future. So some of these are, for example, the elimination of the use of lifetime limits in policies and the beginning phase-in of the elimination of annual limits as well. We see limits on cost sharing in all plans, so that no matter where your source of insurance is, you're only expected to pay a certain dollar amount out of pocket in a year. And we see the subsidization of insurance for people who are earning up to 400% of the federal poverty level. So there's the creation for people who are going to now buy insurance through the exchanges of subsidies for both premiums and for cost sharing, so that they're protected against spending more than a certain predetermined amount of income out of pocket. I also think the expansion of Medicaid falls into this category, although we could see it in a couple different categories, because it actually creates a pretty broad-based access with very low cost sharing. The third theory overlaps with the other two to a large degree, and the notion here is that health insurance should only pay for those harms that are avoidable or random. This is a particularly American conception of health insurance, and it's one that people talk about a lot as the real purpose of insurance. When you look at other types of liability insurance, it's often what people expect insurance to do. So if you have home insurance and you set your house on fire and it burns down, your house insurance is not going to pay for it. If you have a short in a wire and the house burns down accidentally, the insurance will pay for it. Likewise, a lot of people think that the purpose of health insurance should be to pay for those harms that we don't bring on ourselves, and that you should carve out harms that people have in fact caused themselves or contributed to themselves. So there are two different principles for this, what I call the brute luck theory of health insurance. The first is from a utilitarian perspective. We might want people to invest in risk prevention to the degree that it's efficient to do so, while providing a cushion for losses that occur after they've invested. Also from an egalitarian, or maybe more precisely a luck egalitarian position, we might believe that it's not only inefficient, but it's also unfair that people should have to pay for harms they couldn't avoid or prevent. So obviously, as we try to apply this theory to health insurance, there's a very difficult distinction, and a lot of you are probably thinking about this now, about determining how do you isolate and identify what is a brute luck harm and what is individual choice. And this is particularly complicated by research on the social determinants of health that suggests that an individual's poor health, even poor health behaviors such as dietary choices or smoking, might in fact be socially predetermined. So I think the implementation of this, while conceptually clear and an idea that a lot of my students favor and a lot of Americans really like, the implementation is a lot tougher than the idea is in theory. In law, this brute luck theory plays somewhat of a diminished role compared to the other two, but it actually is the motivating force behind several very important policies of the law. So we see it in a few places. We see it in the new risk rating rules that I think actually move us closer to a brute luck theory of risk rating than we had prior in the law. So now when we think about what the factors insurers can use to determine insurance rates, they're only allowed to look at family size, geography, age, and tobacco use. When we think about two of these factors in particular, geography and tobacco use, presuming, of course, that where people live and whether they use tobacco or not are choices that are freely made, these two choices have a significant impact on medical care costs. So charging more for these types of factors moves us closer to at least the theory of a brute luck notion than earlier risk rating did that charged people based upon pre-existing conditions, regardless of whether these pre-existing conditions were the result of brute luck or not. So there was no distinguishing in the past. So there are these three visions of health insurance. One, that it would cover medical care in a way that maximizes health. A second, that it should do so in a way that protects against some level of harms to wealth. And a third, that it should do so in a way that only brute luck harms are covered. Each theory relies upon a different operating principle to determine priorities for what medical services would be covered and where we would spend insurance dollars, for whom and when. So it raises the question, is it really a problem to try to do all three at once? How do we know how much this theoretical incoherence is going to cause a problem? How much do these theories actually overlap? So we can imagine the image I showed in the beginning is that there's some overlap between these policies. So there's an area, kind of up in here where you can actually do all three at once, and there's actually some overlap between these two, and some considerable overlap between the brute luck and other harms. We could also imagine a world where there's more overlap. In fact, there's a large part of policy that we can implement where we can actually meet the needs of all three of these theories at once, and where even if there is some theoretical incoherence in application, it doesn't make a huge difference. We can also imagine a world in where there's not a lot of overlap. So in fact, if you start to implement policy, there's only a really teeny window in which you can meet all goals of all three of these theories at once, and then you have a large area where you're really only going to hit on one at a time. So it may be possible to optimize the overlap and to try to move more towards the center picture, but my sense is that the space outside the overlap will be nonetheless significant. And assuming that we continue to live in a world where medical spending needs are greater than the healthcare budget, I think that we're going to see many times where we need to trade off one of these goals against the other goals. I don't do the work of quantifying that in this paper, but I think that as we start to look at the policies and how they play out, we can see these conflicts starting to arise. So why might we care about this theoretical incoherence? Why might we care about the space outside of the overlap? Well, I'm going to talk about 4 different reasons. The first is the policies, as I was mentioning, may actually be at odds. So we may see what I call discordant policies. Some of the areas where this creeps up in the law are really interesting, and some of them you can see are intentional, and I think will be some of the most interesting areas tracking implementation going forward. So one that's pretty obvious is as we think about the health maximizing policy of paying for first dollar for preventive care, that bumps up against the principles of the true security and brute luck theories in some interesting ways. So it may be antithetical to the true security notion if these dollars that we're now choosing to spend on preventive care are ones that many people could afford to pay for on their own, and in fact were paying for on their own prior to health reform. So now we're taking something that people were paying for, could afford to pay for, and we're using insurance dollars and resources to pay for them. This spending on preventive care might also be antithetical to brute luck principles. So if you can imagine the degree that we pay for smoking cessation programs through insurance, regardless of why a person is smoking in the first place, might offend somebody's brute luck sensibilities. So brute luck insurance policy might not only not pay for the smoking cessation if the smoking were deemed an optional choice that the person made, but in fact it might go even further and not pay for the costs of treating the lung cancer that the person develops down the line in order to create the incentives for people not to choose to smoke in the first place, for people to invest in risk prevention in the first place. There are also a number of other interesting areas that I could talk about more later about where these policies bump up against each other, but I think that's just one interesting one where we think about a decision to spend dollars in a certain way maximizes on one goal and comes into conflict with goals of the other two. So second, I think that having all three of these theories coexisting makes filling out the contours of the law more difficult because there's not a clear roadmap for regulators for the goals that they're seeking to fulfill as they interpret the policies of the law. I'm particularly concerned about that with respect to this law because much of the meat of the bill was reserved for regulation. The law itself punted on many of the tough normative questions, and each time the Secretary has to promulgate regulations, there's potential for this normative conflict to ensue over and over again. So if we think about one of the policies I talked about earlier, the definition of essential health benefits, there's these big buckets of care that are considered essential health benefits. The Secretary of Health and Human Services has to come in and say what falls under this bucket. So let's think about the category of maternity care, maternity health care. If we interpret that in terms of a health maximizing policy, and we're thinking about maximizing the health of the mother, the health of the baby, we may actually see pretty broad-based coverage of prenatal care and maternity care under health insurance policies, requiring that health insurance policies cover this. If instead we were to interpret it under more of a true security way of seeing health insurance and thinking about financial security, it might be that only some of the more expensive services are covered. And non-routine services, or that it's for services of lower income insureds and not for everybody who's insured. If we interpret it under a brute luck theory, it might be that the cost, even if we think about it in an extreme way, it might be that if insurance were only to cover costs that an insured couldn't mitigate, that we might cover very few pregnancy-related costs. So it might be that we only covered a limited set with respect to pregnancies that were not the choice of the woman, that were from coerced intercourse, or that were not from a decision to reproduce. So we can think about a simple policy, one small piece of essential health benefits, and how interpreting that in many different ways could result to lots of different ways of thinking about what it would mean to cover maternity care. So third, I think that, as I was talking about earlier, I think that we make implementation more challenging because we're climbing learning curves on many challenging questions at once. So if all the reform had to do were to prioritize categories of care to maximize health, that's all we had to do was to think about what are the right categories to pay for through insurance if we want to have the healthiest population as possible, and what are the right treatments to use. That would be enough to keep researchers and policymakers busy for many, many years to come. At the same time, however, we're thinking about how do you define financial security, how do you use insurance as a tool to promote financial security, and how do you think about carving out things in order to create the right incentives for people to take care of themselves and to promote their own health. So these are some of the hardest ethical and empirical questions we've been trying to answer and have been researching in the medical and health policy worlds. And the reform requires us to take on all of these questions at once. So finally, the fourth, and one of the reasons that I'm particularly concerned about this theoretical incoherence is that I think it threatens the durability and the popularity of the law. I think that it fuels popular confusion and ambivalence with respect to the value of the law. By deferring the opportunity to prioritize a particular normative conception about what health insurance can and should do, I believe that we actually perpetuate the American ambivalence regarding what health insurance should do. And we make Americans then less able to judge whether the reform is successful or not. So if it were the narrow goal of the reform to eliminate medical bankruptcy and to create a world where we no longer had financial insecurity due to healthcare costs, it would be easy for people to understand that this is the goal of the law and then to measure the reform in the years to come against that goal. Instead, we've created this multidimensional law that's trying to do many things at once, and I think that people aren't fully grasping which of these things are more important, how they all fit together, and are going to have a hard time judging if the law is successful going forward. So what do we do now? So with this paper, I've really highlighted the theoretical incoherence so that it can be considered, but I leave a couple of important questions open. First of all, I haven't really quantified how big of a problem this is. So how many times are we going to see these policies conflicting? How much of a cost is this going to create? How much of a problem is it going to be for the implementation of the law? And I also haven't given strong prescriptions about what we can do if we wanted to minimize. If we thought it were going to be a large problem and wanted to minimize this theoretical incoherence going forward. What I do is I spend a few minutes just thinking about tools we could use to lessen the incoherence if it does prove to be a problem. So first, we could choose to prioritize one of the goals and regulations. It could be that the Secretary of Health and Human Services says that anytime true security and health maximizing goals hit up against each other, we will prioritize health maximizing goals. Anytime they're in conflict, we're going to always go in that direction. We could also think about in the long term how to reshape the law to invest dollars and efforts more in one of these three directions. So it might become apparent over time that one of these three is more favored and is more popular among Americans. It might prove that one of them is impossible to implement and that others are impossible to implement. So for example, with comparative effectiveness research, it might prove over time either that that it's impossible to figure out or that it can't be implemented in a way that's publicly tolerable. And thus we can't fulfill a health maximizing vision of insurance. But true security maybe is more simple and people will buy into it. So it might be that true security wins over time. We invest more dollars in subsidizing health insurance and sliding scale subsidies and a Medicaid expansion while limiting the coverage of preventive care through health insurance. Now that's not to say we would de-emphasize thinking about prevention. It might be that we use other public health techniques and approaches to think about meeting these kind of health maximizing goals, but maybe insurance isn't the right mechanism to do it. Conversely, the opposite might happen. it might be that health maximizing ends up being the big win of health reform, and that it catches on and people are appreciative of the preventative care, are using it, we're seeing health improvements in society, and thus we put more emphasis there. So it might be that it becomes clearer over time which of these is a more easily implementable and more popular element of the health insurance reform. And then we could shift more dollars in that direction. The final thing I think we could do is message the bill more clearly regardless. Now clearly, if we thought about putting more resources into one of the three, then a simpler message would be easier. But regardless, I think that recognizing these different ways that people see what health insurance should do, and then thinking about how do policymakers, how do the regulators message what the bill can do in terms of these expectations people have for health insurance, might help Americans see that the bill has a definable purpose that they can rally behind. So in conclusion, while this paper does not intend to be prescriptive, it doesn't even necessarily say that we need to or must eliminate this theoretical incoherence. What it tries to do is highlight this incoherence for further examination, because I believe that these three different ways people see health insurance and the strong adherence that they have to their own vision of health insurance is a problem and is a potential conflict that I believe might have real normative and economic costs for the implementation of health reform going forward. Thank you.
Thank you. Any questions for Professor Hoffman?
I'll start. First off, I have to say I really appreciated your talk. I thought this was a really interesting way and a new way for me to look at something that I've been looking at for a very long time. So thank you. It was a great talk. But I do think that I need a little bit more clarification on the true security side, because it seems to me that as you were talking about the economic factors, you would sometimes switch between talking about economic factors from the family and consumer point of view, mitigating the risk of bankruptcy and your own financial risk of your percentage of income, and then cost to society, which is the healthcare costs rising and can we afford to put the money here or there. And I do think there was in my mind maybe too much emphasis on how the risks of wealth versus the risks to health, and that those two things are conflicting. Yeah. And I think kind of in the same conceptual framework as Don Berwick's triple aim, which I don't know if you've looked at, but the head of CMS, he has this triple aim idea where you have to do both at once in order for it to come out to be a good system. And so maybe these two things aren't in conflict, but they are two different ideas that we have to figure out a way to do together.
Yeah, it might be that we pursue investment in policies that do both. Maybe that's one of the criteria, is that we have to invest in only the types of preventive care that we also know to be cost saving for the system. Or maybe those are the priorities. First, invest in preventive care or other types of care that we also believe can reduce costs in the system in the long run.
But if we do that, then we're not going to invest in prevention. Because Louise Russell, I think, has demonstrated over 25 years that most effective preventive services do not produce cost savings.
Right.
What they produce is better health for a very low additional cost. So they're highly cost effective, very cost effective, a few $100s per year of life saved relative to other medical interventions. But we're not saving money, and that's.
Right. And that's
but to the system also, they do help people personally, right? So that you don't have a bankruptcy later because of this horrible disease that you prevented. So that's what I'm saying, is that the two economic factors about cost to the system versus cost to people, can be, I think, too muddled together.
So I think that and that's probably in the presentation, the way I presented it. So the true security ideal is really about at the individual level. It's not about at the cost to society level. Of medical care costs, and I think that's what keeps. I think that your point is about prevention, not necessarily being cost saving, and in fact, many people believe it's not cost saving, even though it is high value. So I think that's what keeps these from overlapping. I think that's what keeps it looking more like this than like this, is because in fact, investing in prevention, a lot of things that people think will save money down the line by reducing expensive disease are in fact not necessarily cost savings for the system.
But for the individual, so if the harms to wealth is from the individual side, then investing in preventive services is also cost saving for the individual, so it does both, because it's covering something that you used to have to pay for out of pocket. Now you don't have to pay for that, $500, whatever it costs for the
Right.
MRI or whatever. The mammogram is getting covered by somebody else, and you don't have the copay. So it actually is, from the individual perspective,
It might
both
be,
helpful.
Right, it might be. Or it might be that it creates a different timeline for when your healthcare costs are going to come in your life. It might be that the particular place where you're spending medical dollars now is eliminated, but that it's 10 years down the line is something different that is going to cause you financial insecurity. So it may shift that. So that's interesting. I'll think more about that. Is how investments at the individual level and improving somebody's health can also save them dollars.
I also thought that your talk is very helpful in conceptualizing the different intellectual origins and value origins of approaches to health insurance coverage in society. A couple of comments. One, it seemed to me that some of your points were really much more relevant to private insurance than to public programs, where in public programs the objective is not generally simply avoiding harms to, well, sort of the brute luck harms, but rather more focused on harms to health and harms to wealth. And then again, as I think Jerry was saying, there's not necessarily a conflict between those. The other comment I wanted to make was that I think where I find your conceptual approach really helpful is, and potentially very helpful, is in helping to shape the public dialogue on these issues, which is extremely muddled, as you pointed out from the beginning of your talk, and where that muddling of these different conceptual frames makes it more difficult to kind of thread the policy needle, because you've got people who are arguing about policy when their real argument is about the conceptual frame they're coming from and approaching those policies. So if there's a way to translate this to a broader public dialogue, I think that would be terrific. I don't know if you've given that any thought, or how you might extend that into, let's say, at least the opinion section of the LA Times, something like that. Maybe even the New York Times, or USA Today, where you have a mass audience and maybe could help to engage people and better understand policy debates.
I'll definitely think about that. I haven't put anything like that together yet. I've just started presenting this paper, so the ideas are still coming together. But I'll definitely, thank you. I appreciate that. I'll think about that.
Yeah, following up on Rick's comment, I actually feel like this was a little bit of training for me, because I can think of actual conversations where I've had with multiple other people where we've gone around in these circles, where someone's coming from that one, someone's coming from here, and someone's coming from there, and they're just talking over each other. So for someone kind of in the middle of those conversations, this is really useful to be able to identify this is where people are coming from. So yeah, I agree.
And that's where it started for me as well, was having conversations with people about health insurance and realizing that everybody was talking about something different.
Right.
And that they were not only talking about something different, but they were talking in a very siloed way and seeing past each other, really not being able to connect at all when they were thinking about it.
So I would encourage you to, in the next iteration, do the next level, which is the societal level also, because at the libertarian level, they say, well, if I want to only do high-level deductible for brute luck harms, that's my choice. But what you actually end up doing is you end up costing society, because then when that person can't pay for it, they end up in the county hospital, and it costs them the taxpayers. So there's yet another, you've got sort of the X and Y axis, and you need the Z axis to sort of tie everything together, so that people who might say, yeah, why should I have to buy insurance? I don't want it. It's my constitutional right to be uninsured. It's like why we have helmet laws, because if you are uninsured, you have a high risk then of causing somebody else to pay for it.
It ties back in, actually, I haven't thought about it that much in this paper. My last paper looked at the individual mandate and why we might mandate people to carry health insurance, which is another area where people have very different reasons for thinking about why we would mandate people, and that is definitely one of the three of them. But I'll think more about how that layers in with this analysis as well.
And picking up on Steve's point about the societal level cost perspective, I think that would also help to answer questions about the essential benefits package and about preventive services, because those are, you know, again, the individual may say, well, why, you know, the young man, why should I pay for maternity benefits, or why should I pay for colorectal cancer screening? You know, I'm not even, it'll be twice my age before I'm eligible for that. And I think it comes back to the societal perspective. And I do disagree with a comment you made about preventive services. We all paid for those before, and everybody can afford them. The reality is everybody can't afford them.
Right, which is why the cost sharing has been eliminated.
And the cost sharing eliminated. And the objective, even for those who can afford it, but choose not to because of the very low barrier of co-payments, again, that's the societal perspective speaking about, well, it's better for all of us if you go out and get that mammogram now rather than putting it off because of COVID.
Right. I see that, and I discuss that in a more nuanced way in the paper. But I think the point from a true security perspective is when you take away cost sharing for those kinds of services, you buy out the base as well. So there were many people who were doing that, who could afford to do that, and were doing that before. And the way it's been structured here is not putting incentives in to get people who weren't using it before to use these services, but you in fact use more insurance dollars to pay for it for people who can afford it and were affording it before.
So building on some of the other points that have been made too, I think that, you know, the way that I think about this, and I find your framework to be very useful too, is that there's also a spectrum here of sort of individual versus social responsibility, and which I think plays out with regard to the mandates and many aspects of this bill. And I can't help but feel that where people stand on that spectrum also depends on where they stand relative to where they are in terms of their current insurance status or not. Because one of the things you said early on about this support for some of the provisions of the bill was that you had the subsidies for premiums for low-income individuals. And I actually don't think that there's broad support for that right now. I think that in our community we recognize that health insurance is not going to be will never be affordable, good health insurance, without subsidies. But I'm not sure, I think right now that some of the discontent with the bill is the recognition and the rejection on the part of a portion of society that we're going to subsidize people who currently don't have health insurance, and perhaps in the perception of those groups don't really deserve health insurance. It's the ongoing battle that's and sort of cultural clash and political value clash that's existed in this country for over a century. And I think as people understand that that's what this bill is doing, and using substantial federal dollars to provide subsidies to low-income individuals to buy insurance, I think the majority of certain Americans believe that that's not really appropriate. So I think those cultural and political values help interact with the confusion over the conceptual and help shape some of these conceptual conflicts as well. I think people who are well insured and who have insurance understand that it provides protection for their health and protection against catastrophic. What they don't necessarily agree is that that's something that everybody should have.
Oh, like that new congressman from North Carolina or South
No, from
Carolina.
Maryland.
Oh yeah,
From
voted
Maryland.
himself president.
Yeah.
Oh yeah.
Who voted against the bill and then said, "Where's my health
Where's my
insurance?
health
Yes.
I have to wait 28 days. What's
This is
up with that?
outrageous.
Yeah.
And this is actually,
I'm entitled."
This is now, you know, a value debate which was, I think, almost unique to the United States among the OECD, the more developed OECD countries, and now is clearly infecting Western Europe and threatening the incredible social support systems in Western Europe today.
One of the things that interests me about this and why I came at it this way is that I think that it aligns in some ways with politics and political lines, and in some ways it doesn't. So one of the first things I did on this project is my research assistant Eli Tomar and I started pulling quotes of what people were saying about health reform and how they fit into these theories. And you could see people far left and far right saying things that fit into each of the categories. So I don't know whether that might be more rhetoric than what it actually comes down to in their beliefs, or it might be that they would carve out certain populations of people when they make these comments about improving health or about providing financial security. But that was one of the things that I think really intrigued me, was that as I was watching the debates, I was hearing these notions coming from all kinds of different interesting perspectives. That's one of the areas where I'm still thinking and struggling a little bit, is thinking about how much of this aligns with politics and how much doesn't.
I would say, too, that one of the most persistent comments I get in public presentations on the bill is from people who believe that that the bill is paying for health insurance for people who don't deserve it, not because they're poor, but because they have poor health because of their own fault. So, you know, in terms of that individual responsibility and what's preventable, it's because people are obese and people are smoking, and that's why they don't have good health and good health insurance. And
in this country illegally.
Well, that's always an underlying issue too. But that concern that somehow I'm living a healthy lifestyle, but now I'm going to be subsidizing people who don't take care of their health.
Right. And I actually think that as we see the costs the cost pressures increasing, the kind of the brute luck mentalities, which I would categorize that, and I think we're going to see more prominence of policies in that vein as
because
well.
It narrows the coverage and says,
exactly.
Yeah.
There's some questions back here too.
I guess sort of a couple of questions just graphically here, which may relate to a suggestion, I guess, depending on what the answer is. But it appears that the degree of overlap between the brute luck harms and each of the other two harms, the harms to health and harms to wealth, is the same degree. So I don't know if that's intentional or not. And in the same vein, when the amount of brute luck harm overlap is increased, that the overlap as well between the harms to wealth and harms to health, between the two of those each other, is also proportional at some level. Is that?
It's not intentional. That's just novice PowerPoints. I think empirically, I think we could look at the law and we could actually piece out, or we could think theoretically and look at like the dollars spent on healthcare in the country, and we could actually start to piece out like how much falls into each of these categories. I think it's something that would be a massive project that could be done empirically. I haven't done it for this, so this is like at the pure theoretical level. Yes, there's overlap. I think it's probably something that looks more like that than like this. If you have ideas of how I could do something more precise, we should talk about that later.
Okay, absolutely.
I think one of the really critical issues that people are reluctant to discuss is what was called the death penalty, which put a real negative spin on the idea of at what point do you say that investing in additional medical care is not going to extend the life or improve the quality of this individual. And especially when you consider the massive costs of end-of-life care as a whole, how do we address that really tough issue? Is that totally outside of the scope of this discussion, or how does it fit in?
No, I think it is. I think it is right at the center of this discussion. As I started piecing into these ideas, I realized what they came down to, in large part, were different theories of allocation of healthcare dollars. So each of these theories would determine a different approach to how do you spend like the pool of insurance dollars in a year, and at even the highest level, I think that's complex. And what you're getting at is that as you dig in deeper and deeper, there's more and more complexity. So as we start to think about, harms to health, it's a question of we have a pool of dollars, and then if we want to maximize health, if that's the goal of health insurance, how do we think about using those insurance dollars in a way that maximizes health? And many people would say that Americans, one of the challenges of creating a health insurance system that is contained in any kind of budgetary way in the U.S. is that people won't make those kinds of trade-offs. I think it's, even within that harms to health bucket, the kind of allocation trade-offs and the questions that need to be answered to decide how you're going to spend dollars is highly controversial. And then I think then if you layer on top of it the fact that then you have to trade off between this bucket and this bucket, and maybe between, you know, this red area and the areas outside of it, it gets even more controversial. So I think that that's part of what's the fire underneath these different theories, is that they each lead to different notions of how we would spend healthcare dollars, which Americans are really uncomfortable at talking about in any kind of way that that might involve rationing of certain services. Yep.
So I was thinking about your example of for the great banding and stoppies as an example of group block harms. But I was also thinking that it could also be an example of harms to health, because the idea is that if you can discourage people from, if you can make a certain behavior more expensive by discouraging it, that will, in the long term, actually benefit everyone's health, or that specific individual person's health.
Yeah, I think that's possible. That could be, if we think that the blue block policies would actually deter a certain behavior. So if we think a blue block policy would keep somebody from smoking, I think we would be talking about something that's here in this kind of overlap. And maybe, you know, maybe it saves them dollars as well, at least in, you know, in some portion of their life. So maybe it even is one of the things that falls in here. But I think that's debatable as well. I mean, if we had no coverage of, if we allowed insurers to charge, you know, smokers more, as we do now, and, you know, if we went to the full blue block extreme and said, in fact, we're not going to pay for any downstream harms from your smoking, the question is, how much are we actually going to deter smoking? And then are we going to see the kinds of improvements in health that we would want to see? So to the degree that the blue block policy doesn't necessarily create less smoking, we might see something that, you know, maybe it doesn't fall, maybe it doesn't overlap so much with the harms to health as well. Does that make sense?
I'm not fully seeing this, but it would seem like if you because insurance companies usually do pay for like lung cancer treatment, that, you know, just because you won't pay for, just because in the more short-term area that is preventable, you won't pay for it, but you will if it's the long-term consequence. Again, I guess I just conceptualize that more as a harm to health rather than the root level harm.
So you're saying, let me make sure I'm understanding what you're asking. So so let's say we allow insurers to charge smokers more. And is your question in relation to how we spend those dollars on costs related to smoking, or is it a question in terms of deterrence of smoking?
I guess mine is that you conceptualize, I think, deterrence to smoking as both, well, we're going to make smoking more expensive.
Yeah.
But then, and if you were just to do that, then I think you would be living entirely in a root block harm world.
Okay.
But because there is this combination where it's both we're going to make smoking more expensive and, but if there are health consequences afterwards, we're still going to cover it.
Okay.
Then that's more in that harm to health world.
And that recognizes that there are actually multiple determinants.
Yes.
It's not just
Yes.
a conscious choice influenced by economic factors.
Right, so that might be a middle ground. It might be a balance between saying, okay, we're going to try to get people not to smoke, but if we live in a world where some people are still going to smoke and it might actually not be fully in their control, then we're still going to pay for care down the line. So that's kind of a balance between the two. So if you really thought about the reasons why people smoke and social determinants, you might come to the conclusion that even charging smokers 1.5 times the premiums of non-smokers isn't fair. But maybe it's a balance between the two. Is we'll charge them a little more up front, we'll try to deter that behavior, but because we care about health, we're still going to pay for their treatment. Yeah, I think that's right.
So one last question.
Yes, you mentioned about the healthcare cost variation geographically. I don't know. You mentioned about the smoking rate and all, but I was thinking actually the variation may heavily depend on providers' practice pattern as well as the charging rates and all this, and so I felt like if you do put that as an example, you may need to consider that.
Right. So it may be that the people who choose to live in areas where healthcare is more expensive, that the roots of why healthcare is more expensive is not in their control. It might be something systemically that's going on that's driving up the costs. But then knowing that healthcare is more expensive in X place than Y place, people can still make choices to live in X place or Y place.
But that would vary on the economic factors of labor and
for
housing.
Sure.
Right.
Yes,
Right.
I think there's all kinds of downstream considerations.
Well, clearly this is not a finished product, but it's a great product, I think, and it's been, I've heard a lot of feedback here that suggests that it's going to be very helpful in getting people to think clearly about health insurance and about policy. And so for that, I thank you very much for. I also thank you for sort of being willing to cross the Mississippi River on South
From Upper
Campus Drive
Campus.
and coming down all the way to the southern part of West
South
Virginia.
to south.
And our next seminar will be January 5th. We will let you know what the topic will be. I want to thank Hala for organizing this, as she does.